agree. I think it's time to move on to our next speaker. So I wanted to introduce, or take the opportunity to introduce, Dr. Julie Thacker from Duke. She'll be talking tonight about growing the robotics program. Thanks, Dr. Thacker.
Good evening. Thank you to the organizers for including me. This is Julie Thacker. I'm an associate professor of colorectal surgery at Duke, and I'll be speaking on growing a robotics program through colorectal surgery. Specifically, I've been asked to tell you my story, not because it's unique, but rather because it really isn't. My presentation is how common barriers to robotic practice development presented at Duke, and how we address these challenges. Stories connect the past and present to the future. My hope is that this story might inform yours. To tell you my story, I have to tell you a bit about myself. My current practice is a subspecialty academic-based practice for colorectal surgery. About 62% of my patients are from an IBD focus. Some of these require open approaches, but over the course of the last 2 years, 86% of my IBD surgery has been approached with minimally invasive techniques. Most of these are resections and reconstructions. I do about 1 to 5 ileal pouch reconstructions a month. And about 72% of my patients over the last 2 years have had previous operations in the abdomen. A little over 20% of my practice is specifically cancer not related to IBD and other pre-malignant conditions, including FAP, for which I perform reconstructions as well. And then the remainder are bread and butter colorectal operations in the abdomen and pelvis, including diverticular disease. On review of my cases, all but one in the last 2 years has had some other previous abdominopelvic operation, including hysterectomy, prostatectomy, urogyne procedures, including mesh, and other common abdominopelvic procedures. So I do a lot of reoperating. In addition to that, my one disclaimer is that I'm an early adopter, but I'm fairly stingy. I don't like to take on technology that costs more unless I can prove to myself it somehow helps my technique and helps patient outcomes. The development of my robotic practice really started back to some exposure in medical school and is displayed here. I did a lot of lap cases, but no robotic cases in residency or in fellowship. And then coming to Duke, we had a platform on the SI in 2015 and 17, but not the XI until 2019. Importantly, there were outside factors that also influenced the development of my interest in minimally invasive techniques, as well as the spread of that to colorectal surgery. As shown here, the COST trial in 2014 opened up our use of laparoscopy for colon cancer. The FDA approved the robot platform for GYN in 2005, and there were reports in 2006 of the platform being used specifically in colorectal surgery. Starting at Duke, we had 2 SIs in 2012. However, development of a colorectal program on that platform was unsuccessful. My current practice for major abdominal and pelvic resections is compared from pre-robotic to post-robotic here. Over the last 2 years, I've had around 80% of minimally invasive approaches to most of my major resections. Before being on the robotic platform, 62% of my anastomoses were extracorporeal, including pouch creations, and the remainder were laparoscopically approached EEAs. My outcomes were between just under 1 to 1.5 days of a length of stay for small bowel ileocolonic and right colon resections. Often sigmoid colon resections would fit into the same short length of stay. And I had about an 8% complication rate, including ileus as a complication. For sigmoid, rectal, and ileopouch creation, our length of stay is somewhere between just under 1 day to 3 days, and my complication rate, again including ileus as a complication, was about 12%. About 10% of those complications were related to postoperative ileostomy troubles rather than surgical complications related to leaks or wound infections. Looking at my robotic practice, about 78% of my cases over the past calendar year have been approached robotically. All of my robotic anastomoses, including pouch creations, have been intracorporeal since the beginning of my practice. I have 97 cases to report, hoping to get 100 before this presentation, but just shy. I only did 10 in the first 3 months during a ramp-up period that required proctored cases for credentialing as well as difficulties with scheduling. And the other 87 have been over the past 9 months. My outcomes are recorded down below, showing not much of a difference between my laparoscopic approach and robotic approach. What happened between March of 2018 and March of 2019 such that my practice suddenly changed 180 degrees from almost all laparoscopic to almost all robotic? Well, a lot happened, but most importantly, I had institutional and a teamwork approach to create this practice change. The Duke Colorectal Robotics program had a somewhat stuttering start in 2016, and there were several prohibitive barriers that we recognized. There was not much institutional interest. There was no platform access or block time because it all seemed to be owned by urology or gynecology, because on the old platform, their cases were the only ones that first had approval and then 2 had filled up our block time. There was no industry training specifically for colorectal surgery, and trying to apply the urology or GYN approaches to colorectal surgery had been unsuccessful to us. Industry insistence that we start with easy cases did also limit what we could post onto the robot platform as we were beginning our learning curve. Meaning, if I didn't have a couple of simple lap rights to put on to have a proctor come and watch, I didn't post cases to the robot. And there was a generally held belief that there was no need for robotics in colorectal, as we were accomplishing almost 90% of our cases laparoscopically without increasing any complications and having excellent outcomes by benchmarking. Along with this, we basically had no team, no time on the platform, no training, no perceived need, and I relinquished my robotic privileges in 2017. This was not without notice to the institution, but even at conversation during that time, the institution and I could not come to an understanding as to why keeping my privileges would be of benefit to the institution unless we had a change in our format. To break down the barriers that we had come to realize, we addressed them in each of the different categories. The institution essentially had an attitude that we needed to prove that we needed the robot for colorectal, and then they might consider buying one, where instead this became more of a growth and innovation model. Where we previously had no access or block time, with very few surgeons being in charge, a bigger vision was created, realizing that if we had available resource, we could certainly work to make the schedule more accessible. With no training previously for colorectal surgery, industry realized this need and also created groups of surgeons who were able to work together and develop specialty training specifics. This insistence to start with easy cases still persists, but I'll have to admit I ignored this and would say that this idea is now somewhat debunked for me. I would not recommend that you start only with the easy cases, but rather start with cases you would expect to be able to accomplish laparoscopically, such that the only hurdle you need to overcome would be changing your platform, not completely taking on a case that might not be something you could accomplish by minimally invasive techniques anyway. And having no need for robotics, well, potentially this was still true at the time of my adoption of robotics, but I've come to realize that if I challenge myself, there are several things I can do on the robotic platform that I can't necessarily accomplish with straight laparoscopy. The very specific turning points that I recognized in development of my robotic program was to look at the institution and industry. Suddenly, it was possible for us to participate in a play-to-pay model, which was a 180-degree turn for administration. If they were able to bring the platform into our operating rooms and we used it, they would not only be paying for a robot at the same time as billing for those procedures, there was minimal upfront cost for them to participate this way. Once we had access, we realized that the vision of a full robotic utilization became much more important than having someone own a block. If an owned block went unused before, there was really no loss to anyone because we had already paid for the platform. Where now we needed to fill the block, and there was huge investment in making sure that block time was available to optimize utilization. Again, 180 degrees from how we used to manage our OR utilization time. And what did we do to make sure we were ready? All of a sudden, if we were going to have a platform on which we would do billable cases, and we would only be paying for that platform in the event that we used it, there was a great deal of motivation to spend the time and money to train our teams. There was also motivation to spend money to create a first assistant group, which then could also bill as assistants. And Intuitive specifically created a colorectal surgery training platform. This was included in the administrative conversations as essential to our potential success. This included site visits, simulation training, and colorectal faculty lab experience. There were also colorectal-specific care proctors who visited Duke to help us towards our privileging and proctored cases. There was expanded representative availability as well as specialty experience. This institutional, departmental, and surgeon alignment allowed conversations and new thoughts around a less limited resource. Suddenly, when we went to post cases, listing a case as robotic was just another way to post, rather than trying to change an entire system at the same time as accomplishing an operation. Figuratively, this is what our experience looked like. We had a custom pricing model and renewed institutional interest given this. We identified the requirements for success to include a trained team, surgeons who were particularly interested, and a recognition that industry needed to be with us to represent the platform, and our recognition that they weren't there to teach us how to do the operations, but rather how to do our operations through their platform. And then my last point will be to discuss some of the expanded skill sets that a robotic approach allows to complete operations in a minimally invasive approach that might not have otherwise been possible. For these, I include a list of deep pelvis, intracorporeal anastomosis, left colectomies that are just annoying. You can do an intracorporeal anastomosis for those now. And, of course, assisting all of our colleagues who have been on the platform for a long time. This is one of the main pieces of our successful conversion to a robotic colorectal surgery platform at Duke. We previously had 2 robots available. Utilization was assigned to those services who already had use. If I were to look at this and say, well, I'm general surgery, I could try to use some of the general surgery time, noting that there was none designated specifically for colorectal, and I superimposed my OR block time, which was a requirement to request robot time. I had essentially 3 days per month that I could request the robot. If I then, on top of that, superimpose the third filter of only assigning myself easy cases on those days, I would go months before I would be able to take advantage of a 2 case per day robot block on any of my OR assignments. The key piece to changing this was to open up our utilization profile, but also get more equipment. In 2008, we expanded to include XIs, going from SI to XI and increasing our numbers. At the main Duke Hospital, where we have most of our trainees stationed throughout their residencies, we have 4 dual console XIs now, 2 at Raleigh Hospital and then another at the Duke Regional Hospital. With this, obviously, when you look at the 4 robot platform at Duke North, availability is almost more than doubled. But importantly, superimposed upon this, we created a schedule that considered when the individual surgeon's interest in robotics had also OR block time, availing me to at least 1 day on the platform every week. Additionally, there were general surgery and colorectal blocks that were not yet assigned that were available when I started my proctored cases and reestablished my credentialing. Therefore, I had a lot of availability at the beginning, which allowed me to be flexible and get on the platform more often than ever before. The foci of the colorectal surgery robotic platform reset at Duke was really one in change management. At the institution level, we worked to have frequent reporting back and forth, and we encouraged everyone to be enthusiastic at what we could accomplish rather than our previous challenges. For access and block time, as I've already shown, we had very frequent and intentional conversations trying to pair robot availability with already assigned operation room block. There was a need for engagement with leadership to get advice around training. We had to have some back-to-back days in the operating room on platform to avail ourselves to proctor visits. We also required a circulator and a half at the beginning of each new OR workday to manage all of the equipment until they became more familiar. And at the administrative and School of Medicine side, we had to arrange for coverage, allowing for training, site visits, and ramp-up team meetings. It was important to develop a willingness to accept fewer case postings in that each case took longer at the beginning. And we also had to accept that our schedules were going to be a mess for a bit. The training and the commitment to taking this on was substantial at the beginning. I completely repeated all of the industry and institutional training and privileging requirements. I did attend staff training sessions with the OR staff and the nurses to make sure that I encouraged and created a team presence around this. Importantly, exceptional team care and personal care became a focus during this time. There are several unique aspects to being a mid-career surgeon and taking on the learning curve required to adopt a robotic platform to an established subspecialty advanced minimally invasive colorectal practice. This is stressful for the team as well as it was stressful for me, and here I've listed several things I tried to focus on that I think were important to my success. Showing up for my team early and making sure that I had a team building focus. I also admitted when I didn't know the perfect instrument or the length of a suture, and I intentionally recognized many of the superstars who hung in there with me as I went through this. For myself, I took notes, I watched videos, I had very intentional time with the representatives and the surgeons who were available to me to help. I also approached my schedule differently by decreasing other duties and accepting a decreased caseload during these first few months. While the platform is capable of decreasing the neck strain and some of the strain on smaller hands with laparoscopic instruments, it certainly created a whole new stress physically, with a few more headaches and fatigue and hand soreness at the beginning. As I went through my learning curve, I made a point to set and celebrate personal goals, recognizing when I had learned my favorite instruments, when I got that right colon time down below 2 hours again, and when the addition of a second major case in the same day on a robot day no longer became as stressful as the first few times. I also worked hard to keep an open mind to figuring out what was possible on the platform. As I'm sure will be better detailed by some of the experienced robotic surgeons on this agenda, I'll just mention a few ways I've been pushing my skill set to maintain minimally invasive approaches to operations I like to do. My cases, previously known as lap until planned small incision, I estimated to be about 20%. You know, that bladder fistula you close through the small phalansteal, or the mesentery that you manage through a little bit larger stoma incision because our laparoscopic instruments just couldn't handle it. On thorough review of my first year on the robot, there were 36% of my cases that I would have put into this category, a total of 37 cases, and all of these I could complete on the robotic platform when I would not have been able to do it with the straight laparoscopic instruments. These included intracutaneous fistulas, fistulas to the bladder or vagina, contained perforations in IBD, and that difficult to manage mesentery of the Crohn's patient. In general, my experience has been, as an institution and a team, I believe we have found that an administration can make or break just one surgeon's effort, but when working together, we can really make it happen. Planning and flexibility is essential on both sides of this equation. Our industry partner is a member of that team, not just someone we have to work with. They bring cultural memory of successes, as well as they can act as cheerleaders, cost containment advisors, and certainly storytellers. Mid-career learning in surgery is stressful, and I urge surgeons new to this to take care of their teams and of themselves. Realize that this also is compounded in academics, especially with learners present in the operating room. And specifics to colorectal, again, just do it. Don't look for the easy cases, but approach cases that you would normally approach laparoscopically as the first ones that you would be willing to do on the platform. Remember that the robotic XI port placements are not graceful as laparoscopic port sites, and that you should just persist rather than convert. Friends and videos help learning again, just like we used to do in residency. And learn the platform to expand your skills, realizing that multi-quadrant approach with the robot platform is fairly unique to colorectal, and we have to learn it and then teach it to each other. Thank you again for including me, and I look forward to the Q&A.
Dr. Thacker, that was a fantastic talk. And again, you're a real expert in change management with all of your ERIS work and obviously working your entire team through the whole process. One of the questions that came up on the thread was about, are you actually better with robotics than you were with laparoscopy? I mean, you're an accomplished laparoscopic surgeon. Are your patients really doing better with robotics?
Thanks for the question and for including me in the program. I think so. I think the patients are doing better. I don't have numbers of cases enough to express to you some powered significance, but I certainly have noticed that the incidence of GI dysfunction, which is likely relative to bringing the bowel out of the body through a very small hole, getting venous congestion, doing the anastomosis and dropping it back in, not doing that anymore, I think, is probably less stressful. And it seems as though patients are recovering more quickly. Certainly, we could combine experiences across enhanced recovery centers, or I'll wait it out and get enough patients to be able to write it up myself.
Awesome. What the second question I had was, it's always surprising to me that hospital administrators want you to prove that you need a bridge before you build the bridge. Can you just, again, talk about how you changed the financing model for your robotics practice?
Sure. I'll admit that I didn't change that model. That that was an agreement that came from discussions from the surgeons who are already involved in robotics, a discussion with Intuitive, and then a couple of other models that were available nationally. But when that was proposed, I certainly was joining in the conversation and reporting that I would be interested if we could do something about availability to the platform. Our first go through was really very limited, and I was forced to try and trade OR blocks and find any available time, most of the time following someone else, meaning I had to have an OR day that I would give up half of to then wait to be on the platform. And it was really never conducive to even completing a cursory learning curve and getting used to the platform before I could be on. But relative to the institution changing their perspective, I came to the table at the time when they were trying to figure out if it would be useful. And I was certainly someone who said, I will do this if you are able to build it.
Fantastic. I know it was a really important part of our change here at Mayo Clinic in terms of changing from a capital intensive process to really an expense based model, and it certainly opened up a lot of access for our surgeons. Eric, question for
Yes,
you.
great, Dr. Thacker. That was very enjoyable, and I'm going to say that I relate to a lot of your story. It seems much more intense, all of the twists and turns that you went through. But some of the things that I can relate to, and I want to see if those that are listening to us relate to, is this notion. I like it when someone says, if you build it, they will come. So give us the robot, give us access as a colorectal service line. We're generally doing colorectal service line work. But a lot of times the hospitals, like it seemed it do, what, especially ours in Houston, are saying, well, if you do it, then you can have access. And we're stuck because we're doing cases late or we're taking weeks to get the robot. It is very, very frustrating. But one thing that worked for us was me knocking on a lot of doors. And basically, we made a deal and we said, listen, we will tell you that we're going to do so many robotic cases a week. That's basically what I said. You know, we guarantee every Wednesday, you know, this is for an example, we're going to do 2 cases every Wednesday, guaranteed. Can you give us that slot? And our hospital doesn't even have block time. They have pseudo block time, but that's really what it took. And that might be something I suggest, because if you're just having to struggle and post when you can, like you were saying, boy, it's really hard to get the ball rolling and to get a good, consistent atmosphere going.
That was definitely one of the most challenging aspects of the ramp up of my program. I approached it in a couple of different ways. One was to make sure that everyone knew I would be interested. I did go through the privileging process before, and I certainly visited very often into the rooms of the people who were doing robotics and also on our local committee. Wow, this is great. Oh, I'd love to help, but I don't have robotics yet. Oh, I would like to have more time on the platform. And as the questions started coming to me relative to our institution, whether or not I would be interested, I started providing a weekly report of the cases that I had done laparoscopically that I would be posting to the robot platform if I had privileges and also availability of platform. They started getting tired of those emails and they started inviting me to the committee meetings. And we also started having a little more vigorous discussions as to when that could happen and how pushing the idea of colorectal surgery being in robotics at Duke became a reality. I also had partners who were not in my specialty and not even so close to me as far as a division, but our cardiothoracic program also developed a robotic platform in parallel to my work in surgical oncology. So being able to do that along 2 different divisions was very helpful at the time when an institution had a lot of questions.
Julie, again, so interesting. One of the comments that I had regarding this was, you know, we try as a community to work and help each other with our training. You talked about partnerships. So tell me a little bit more about how you kind of got on board in terms of, did you do a lot of mentoring? Did you watch? Did you go see surgeons operate? Did you utilize any of that? You mentioned proctoring. Just maybe walk me through that again.
Sure. I would say it was very unsuccessful when I went through it and we only had the SIs in-house. But the second time through, I found the training through Intuitive, as well as what I was able to accomplish at home with some mentors, was very helpful. I started again in the lab. I started on the modules on the computer, which were much better this time around than they were when I looked at them in 14 and then looked at them in 12 and did them in 14. I also went to 2 separate labs, and I was involved in labs with colorectal surgeons. So my questions about how do you manage a splenic flexure and get down deep in the pelvis with these particular ports, or how can I manage the thick mesentery of a Crohn's patient, were now met with surprise and discussions of doing pelvic adenopathy surgery by GYNs. It was really very particular to what I was hoping to accomplish. And then when I came back home, we have a lab for the residents. I was able to spend time on platform and do practices there. And then once I was ready to get into the OR, I did have mentors locally who were in the pelvis every day in urology, urogynecology, and also in GYN oncology. So I was able to be in the operating room with other folks working in the pelvis. Interestingly, I did find that it was much easier this time through, having had my training with colorectal surgeons, to approach the posterior pelvis, as opposed to all the help I had had previously looking into the anterior pelvis, where the training was predominantly for urology and GYN. There's a difference in how you look at using the camera differently, using different setup for the ports, just a little bit different, but really substantially important in my being able to take on this platform, was shifting that focus to being true approach to the colorectal approach of the pelvis.
I just have a question on one of the slides that you had. You said something in there about this 20%. I was talking more about, you're doing laparoscopic surgery and you're quote extending the incision or making a fanny. Can you go through that a little bit more? And why are you finding that less frequent with your robotic approaches now?
Sure. So I actually didn't realize that I was doing that as much as I was doing it. So when I would take on cases, I would post them laparoscopically. I'd get into the OR and I'd have to decide, okay, how am I going to manage this hole in the bladder I'm going to have when I disconnect the colon from it? How am I going to manage these 3 loops of bowel that are all connected, and when I open them are going to spill everywhere in the abdomen? How can I get that EC fistula down, not just from the outside, but also from the inside, and manage this laparoscopically? And most often my answer was, I had some way of containing everything down to one move. And that meant, is it going to be close to a stomosite? Is it going to be close to the place where I'm taking my specimen out? Or is it going to be closest to a phalansteal? As I changed to the robotic platform, of course, all of my port placements changed. And all of a sudden, my little tricks and things I was doing laparoscopically didn't fit into the same port sites, rather. And so as I worked, I realized, well, I don't know where I'm taking this out yet. I'll just keep working until I can figure that out. And more often, I realized, oh, I can just get this done. So obviously, I can sew a hole closed in the bladder. Obviously, I can take down a fistula and close it. All of the things that I felt like I could not accomplish with the straight laparoscopic instruments, I was suddenly able to do, and didn't have to plan to bring that out of the abdomen to manage, either without contamination or to manage at all. I find sewing at difficult angles after taking a sigmoid phlegmon off of a colovesicular fistula very difficult laparoscopically and time consuming. And so it was much easier, since I had to have some incision somewhere to take the specimen out. I would just make the phalansteal a little bit longer in that site and then be able to do my repair through there. And I don't need to do that anymore. I'm able to approach these with the robotic port placement and the robotic instruments without needing to do that. The review was interesting because going back to my lap cases, I certainly didn't have in my op note or in my case log, oh, I wish I hadn't made this incision. But I could certainly look back at my cases, and I was able to see that it was probably about 20% when I was laparoscopic. And certainly I kept track when I was going through my robotic learning curve. And I said, wow, I would have made an incision at this point, and I didn't have to. And being able to do that through my first year really proved to me that I can do more on the robotic platform than I can do with straight laparoscopic instruments.
Great, excellent. Thank you so much, Dr. Thacker. We really appreciated that and your comments to follow. We're going to now make a transition to our next session. I do want to make a comment, though, that for me it was the exact same way. I think it was more than 20%, quite frankly, when I was doing laparoscopic surgery. The so-called, we're going to extend our incision, it extends a lot more than you usually think. And we're finding that less and less frequently with the robotic platform. So I agree with you there. And thank you very much.